First speaker is Dr. Sunil. Second speaker is Dr. Madam. Third speaker is Dr. Nidhi. Fourth speaker is Mark. Speaker is Dr. Neha. Sixth speaker is Dr. Pooja. Seventh speaker is Dr. Ram. So all are joined and all the NB is everyone, all have listened to the fungal kinetics and all the talks, and now they are going to listen to the their own speakers. So over to Dr. Bharti Sharma. First speaker is Dr. Sunil, Professor Sunil.
Yes.
Professor Dr. Sunil, please start your presentation.
Yeah. Just
So Dr. Sunil will be speaking on corneal dystrophies and degenerations. Sir, share your screen.
Yeah, I'm doing.
Yeah, thank you.
Is my slide visible?
No, still not visible.
Okay.
Yeah. Can you go to the slideshow?
It's visible now?
Sir, please start.
Yeah. Thank you. Good evening, everyone. So I will be basically speaking on the corneal dystrophy and degenerations. So I have made this talk mainly for the postgraduate purpose. So I will discuss the basics. So what is corneal dystrophy? The corneal dystrophy is a heterogeneous group of corneal diseases which are hereditary, bilateral and symmetrical, occurs at younger age. It is generally slowly progressive, not related to any environmental or systemic factors, affect the central cornea first, and they are generally non-inflammatory and without any vascularization. But there are exceptions to all these points, like EBMD and CCDF. They are generally non-hereditary. PPCD could be unilateral. FPCD, they are Fuchs endothelial dystrophy. They affect generally in the 4 to 5 decades. Snyder corneal dystrophy are associated with the one systemic factor like hypercholesterolemia. Macular corneal dystrophy affects the entire cornea, and GDLD, we all know it is associated with the significant vascularizations. Then another important question, what is the difference between degeneration and dystrophy? So degeneration generally affects 40 years of age or above, whereas dystrophy occurs at a younger age. Degeneration is generally unilateral but could be bilateral but asymmetrical, and dystrophy is generally bilateral and symmetrical. Family states are uncommon in degeneration and common in dystrophy. Location, the degeneration generally starts at the periphery, then go to the center, and dystrophy started at the center. Vascularization are common in degeneration, whereas it is uncommon in dystrophy. And environmental systemic factors may be associated with degeneration, but not in case of the dystrophy. So there is the International Committee for the Classification of Corneal Dystrophy. We call it IC3D classification, and third edition has been come in 2024. So what basically IC3D basically did is they categorize all the corneal dystrophy into 4 categories based on the genetic knowledge. So category 1 include the corneal dystrophy, which is well defined clinically. The gene has been mapped and a specific mutation has been identified. Whereas category 2 includes well defined dystrophy, a specific chromosomal loci has been found. And category 3, when we have only the well defined clinical entity, but not had been mapped to any particular chromosome. And category 4 includes any suspected new or old dystrophy. And we also to understand that any particular corneal dystrophy may move in between categories. Suppose a corneal dystrophy in category 3, and if we found the chromosomal loci, then that corneal dystrophy will move to category 2, and we map the genetic mutation, then it will move to the category 1. The IC3D, they also classified according to anatomical classification. So they basically did the four groups. One is the epithelial and subepithelial, then epithelial stromal, then stromal, and lastly endothelial dystrophy. So epithelial and subepithelial dystrophy includes EBMD, epithelial recurrent erosion dystrophy, subepithelial mucinous corneal dystrophy, Midgman, least epithelial dystrophy, and the gelatinous drop-like corneal dystrophy. Then we have the epithelial stromal dystrophy. They are called the TGF beta associated dystrophy. And the features of this group is they all are associated with some form of the recurrent corneal erosions. And it includes the Ridge-Buckler dystrophy, Thiel-Behnke dystrophy, lattice corneal dystrophy, category granular corneal dystrophy, type 1 and type 2. Then the stromal dystrophy includes many, but the common one are the macular, the Snyder, the congenital stromal corneal dystrophy, flax corneal dystrophy, posterior amorphous corneal dystrophy, central cloudy dystrophy trunk-wise, and the predestined corneal dystrophy. Then the most important is the endothelial dystrophy, the fixed endothelial corneal dystrophy, quite common. Then posterior polymorphous corneal dystrophy, congenital hereditary endothelial dystrophy, and the X-linked endothelial corneal dystrophy. So another important question asked in the exam, what is the inheritance of all these dystrophies? So most of these corneal dystrophy are autosomal dominant, except the macular corneal dystrophy and gelatinous drop-like corneal dystrophy. They are autosomal recessive. And X-linked endothelial corneal dystrophy, as the name suggests, they are the X-linked. Previously, the least epithelial dystrophy was supposed to be X-linked, but it is now under the autosomal dominant category. And as I already mentioned, the EBMD, epithelial basement membrane dystrophy, and CCDF, they are non-hereditary. I will discuss all these dystrophy in brief. So EBMD, or epithelial basement membrane dystrophy, it is the most common dystrophy, also known as the map dot fingerprint dystrophy. And patterns of lesion may be in the form of the maps or dots or the fingerprint lines. They are generally asymptomatic, but they sometimes can be associated with a recurrent corneal erosion and can cause the irregular astigmatism. Then Measurements epithelial dystrophy. So when you examine the diffuse illumination, we see the gray opacity with a very distinct border. And with relative illumination, all these opacities are composed of the multiple solitary transparent macrocysts. They again are generally asymptomatic, but recurrent corneal erosion may be occurs. Then we have the least epithelial corneal dystrophy. It is similar finding, but it is more severe than the measurement corneal dystrophy. We have the localized gray opacity in different patterns. And retroillumination, we see that these opacity is composed of the multiple tiny, densely crowded clear sheets. Again, they are generally asymptomatic. Then we have this notorious corneal dystrophy, gelatinous drop-like corneal dystrophy, and it is autosomal recessive. And they are associated with a significant decrease in the vision, photophobia, irritation, redness, and lacrimation. And the vascularization is the typical feature of this corneal dystrophy, in contrast to the all other dystrophy. It could be in the form of the band keratopathy or mulberry type or the Kumakwet-like diffuse stromal opacity. And the recurrence is the features of this dystrophy. If we do the surgery, then they might be the recurrence. Then Ridge-Buckler corneal dystrophy, there is the confluent, irregular, and coarse geographic or reticular opacities with varying density. They develop at the level of the Bowman's layer and the superficial stroma. They are initially more central and then discrete and subsequently extend to the limbus and deeper stroma. On anterior segmentosity, we see the sharp hyperreflective band at the Bowman's layer. Then we have the Thiel-Behnke dystrophy. It is less severe than the Ridge-Bucklers. And there is a symmetrical subepithelial honeycomb opacity, peripheral cornea typically uninvolved. And in anterior segmentosity, we have the typical sawtooth pattern of the hyperreflective material deposited at the Bowman's layer. So this is the comparison of the anterior segmentosity between the Ridge-Buckler. And in the Ridge-Buckler, we have this sharp border, whereas in the Thiel-Behnke, we have the sawtooth appearance. Then lattice corneal dystrophy. Here, patient present with the refractile dots or branching lines in anterior to the mid-stroma. The lines gradually thickens, the branch and collage, but the intervening stroma remains clear. Then we have the granular corneal dystrophy. This is the type 1. We see the small, multiple, discrete, white, sharply demarcated breadcrumb or snowflake-like deposits in the anterior central stroma. And peripheral 2 to 3 mm of cornea generally are spared. And also the intervening stroma are clear. This is the type 2 granular. It is also called the Avellino dystrophy or combined granular lattice dystrophy. And here we see the features of the both, like a star and disc-shaped discrete stromal opacity and diffuse and retroillumination. Sometimes they can present with this denser and more confluence opacities. Then the macular corneal dystrophy, this is the most severe among these stromal dystrophy. They are autosomal recessive. And it is most severe, but fortunately it is the least common. Initially the central superficial irregular whitish plaque-like opacities develop and can later involve the limbus and the deep stroma down to the descemet membrane. Simultaneously, a progressive diffuse has developed to involve the entire corneal stroma. The larger central macules are located in the superficial stroma, with the smaller and more discrete peripheral opacity are located in the deeper stroma. So this is how to differentiate between three classical stromal dystrophy, that is the lattice. In the lattice, we see the dots or the lines, whereas in granular, we see the multiple discrete opacity. And in the both all these, the intervening stroma remains clear. But in macular corneal dystrophy, we generally see the diffuse corneal edge and the multiple white opacity, which are with indistinct margins. Then among the endothelial dystrophy, we have the Fuchs endothelial corneal dystrophy, mostly affect the 4th to 5th decades. But we can remember that early onset variants are also there, which can present in the first decade also. Females are more affected than the males, and the typical symptoms include the early morning blurring of vision, pain, photophobia, and watering, and the decreased vision. The signs include the confluent central corneal guttae, pigment dusting of the endothelium, copper-beaten appearance of the endothelium, epithelial edema and bulli formation, then a stromal edema, and finally we have the scarring and vascularizations. The FECD is typically described into 4 stages. The stage 1, when we have only the central corneal guttae and patient is generally asymptomatic. In a stage 2, when the endothelial decompensation starts and patient can have the stromal edema, and patient initially present with the early morning blurring of vision. In a stage 3, when the patient develops the epithelial bulle, we call it bullous keratopathy, and when this bulle rupture, patient will present with the pain, photophobia, and watering. And stage 4, when we have the scarring and vascularization, and patient will present with a severe decrease in the vision. Then we have the congenital hereditary endothelial dystrophy, which is because of the mutation in the SLC4A11 gene on chromosome 20p13. And here the patient generally presents with the bilateral, symmetrical, slowly progressive corneal cloudiness, typically involves the entire cornea from limbus to limbus, and generally occurs in early infancy or neonatal age and rarely in the adults. There is no associated photophobia or epiphora, and it can be associated with the significant visual impairments. Then how to manage this corneal dystrophy. So I will summarize how to manage all this corneal dystrophy. So it depends if first is that symptomatic treatment to relieve the ocular discomfort or pain, and this is because of the recurrent corneal lesion. So conservative treatment will include the lubricants, hypertonic saline drops, patching, and the bandage contact lens. And surgical management includes the manual epithelial debridement, superficial keratectomy, anterior-stromal puncture, superficial diamond burr polishing, and sometimes PTK can be done to manage this recurrent corneal erosion. Then we have this functional treatment to improve the visual acuity. It depends on the level of the stromal involvement. So PTK can be done if the stromal involvement is less than 100 micron, and lamellar keratoplasty when the involvement is less than up to 250 micron, and we can do the dark if the involvement is more than 250 micron. Then obviously we can do the endothelial keratoplasty and endothelial dystrophy like FECD and CHAD. And penetrating keratoplasty is sometimes required, especially in cases of the macular corneal dystrophy, a stage 4 Fuchs dystrophy, and severe CHAD. And if the FECD Fuchs dystrophy is associated with the cataract, we can do the sequential surgery, but we have to protect the endothelium using the dispersive viscoelastic. And we can also do the triple DSEC or DMAC if the cell density is less than 1000 or CCT is the more than 650 micron. So with some example, this patient present with the Fuchs endothelial dystrophy present with the PBK, and we did the DSEC surgery and patient with a good visual outcome. This is the 13-year-old girl with bilateral CHAD, right eye very severe CHAD and left eye moderate. So we did the right eye PKP and left eye DSEC with good visual outcome. This is another 14-year-old boy with bilateral CHAD, and we recently did the left eye DSEC surgery, and this is the 3-month photograph, and patient had 618 or 624 visions. Another girls with CHAD, and we did the PKP in this case. Now I will briefly describe the corneal degenerations. So the important ones are the arcus senilis. This is the most common. Everyone has seen this. And this is because of the deposition of the lipoproteins. It generally starts superiorly or inferiorly, and there is always some lucid intervals. And if it occurs in the younger age, it is called the arcus juvenilis. And we have to rule out the familial hyperlipidemia in these cases. Then crocodile sagrin, there is a central corneal opacification, the typical appearance of this mosaic-like appearance, but they are generally asymptomatic and visually and clinically not significant. Then spheroidal degeneration is very important. It is also called the CDK or climatic droplet keratopathy or Labrador keratopathy. And golden brown spheroid deposits are there in the superficial stroma. It could be primary or secondary. So primary will be bilateral, occurs in the interpupillary region, and they are generally associated with the UV exposure. Whereas secondary occurs in the prior corneal scar and associated with the vascularization. And treatment includes lubricants, PTK, superficial keratectomy, and the lamellar keratoplasty. Then we have the Salzman nodular degeneration. They are the single or multiple grayish-white elevated subepithelial nodules. They are generally associated with the chronic inflammation, but the intervening cornea remains clear. Could be associated with the dryness of foreign body sensation, and treatment includes lubricant, PTK, or superficial keratectomy. Then band separate keratopathy, very common. And there is the deposition of the calcium hydroxyapatite in Bowman's layer and superficial stroma. It starts peripherally and grows toward the center to form the chalky white band in the interpupillary area. And there again the lucid interval, and there are also lucid holes in the lesion, and this is because of the corneal nerves which passes through the Bowman's layer. The causes include the chronic uveitis like GRA, elevated serum calcium or phosphorus, silicon oil filled eye, thysis bulbi, mercury exposure, etc. And treatment includes chelation with DTA and the PTK. So just to conclude, it's important to know the different types of the corneal dystrophy and degenerations, and making correct diagnosis will help to decide the line of management, prognosticate the patient as well as the genetic counseling. So thank you.
Thank you, Professor Sunil. Now over to Dr. Bharti Sharma. She will present her talk, and please stick to time 10 minutes because otherwise other speakers will not be able to finish because the students will get very tired. It's already 9:10.
Sir, can you stop? Yeah. Sharing the screen. So, are my slides visible?
Yes, visible.
So, good evening, everyone. And so, it has been a very long topic, very important one. So, most of my topics have been covered by the earlier speakers. So, I will be going very fast. So, I'm going to talk about corneal ectasia and the management. So, dear PG students, what does ectasia mean? It means a non-inflammatory condition which is characterized by progressive thinning of the cornea, which leads to astigmatism. Cornea ectasia gradually changes the shape of your cornea. As a result, the sharpness of the vision reduces with time. It usually affects both the eyes, but occasionally just affects one. So, what are the most common conditions that come under this terminology? Keratoconus, already discussed. Keratoglobus, we have pellucid marginal degeneration, which is another form of keratoconus only. We have post-LASIK ectasia and post-penetrating keratoblastic ectasia also. So, what is keratoconus? It is a disorder of the cornea which is characterized by progressive thinning and ectasia, which results in deterioration of the quality of vision and also the quality of life. So basically, what happens in keratoconus? It is when the central or the paracentral cornea undergoes progressive thinning and steepening. It causes highly irregular astigmatism and poor quality of vision. It is very common in Middle East, India, China, and Australia. Usually presents early in life, in early puberty, and progresses up to third or fourth decade of life, after which generally this disease tends to stabilize. So, what are the risk factors? Eye rubbing, sleep apnea, any connective tissue disorders, floppy eyelid syndrome, retinitis pigmentosa, positive family history of patients with keratoconus is there, Down syndrome. Suddenly, you find in pregnant ladies, this condition has been very quiet and it flares up. Hypothyroidism. So, when a patient comes to you, I have kept this talk very basic. Considering postgraduate students, how will you recognize when a patient walks in the OPD? So if you sit and see a patient on the retinoscopy, you are doing a refraction. So you will see that scissoring reflex. Autorefractometer, you will see the crowding of the Myers. Keratometer, external examination, slit lamp, and the corneal topography. So on a retinoscopy, typically you see a scissoring reflex. That means when two bands reflex appear, they move away from each other. And also on direct examination, if you just put a direct ophthalmoscope and you are seeing the reflex, you will see this oil droplet sign. All these points are very important because they will be asked in the exam. Now, when you put the patient just to take a autorefractometer to take a reading of the refraction, you will typically see this crowding of Myers. So this should alert you that something is wrong and cornea is deep in the area where the crowding. So the first diagnosis starts right here. Until you do the refraction yourself, you might miss the patient. So crowding of Myers, this is a Bosch and Lomb keratometer. So when you see the patient just sitting there on the slit lamp, in very advanced cases, when you ask the patient to look down, and then you see the V shape of the lower lid, this is known as monsoon sign. Then in very advanced cases, again, you have this residutis sign. That is when you shine a pen light on the temporal side of the eye, it causes light to focus on the opposite side. This is because of the extreme corneal steepening. So very beautifully demonstrated. So how will you, after you have seen the slit lamp, I have come basically to the investigation part of it. You have seen, you have a doubt. Very early cases, you might just miss them on the slit lamp. Suppose there is no Fleischer's ring, there are no Vogt striae. How will you see? You have to do a topography. So these are, the one of the old topography machines, TMS. So, what are the basic maps in the sagittal maps that you see? What are the different patterns of the cornea? You have round, oval, superior steepening. The red areas are the areas where the cornea is steep, and the green is the normal cornea. So, you can see the superior area is steep, then inferior steepening, irregular. So, symmetrical bow tie, asymmetrical bow tie. You should know that when there is an asymmetrical bow tie, when inferior steepening is there, these are the cases where keratoconus is most common. So nowadays we all are using pentacam, and then after that Sirius and other modalities have come. So what is a pentacam? Why it is more? It is so much better than the earlier topography machines because it uses a Schemflux technology. So basically, when you see a pentacam map, you will have these four maps. The first is the sagittal map. The second is the elevation map front. Down will be the elevation map. And then you will have the Pachy map. That is the thickness map. So all the informations you will get in the one screen only. So what is important is you should understand what are the elevation maps. Basically, what happens is the back of the cornea and the front of the cornea, the data is compared as compared to a reference sphere. The analysis compares the corneal back to the best fit sphere. You will see it on the map, which is typically usually we keep around 8 millimeters. And then you have color codings. Any area of the cornea which is above the reference, that is, which is more steep, will appear red. That is the anterior elevation, and which goes down is the blue. So this is typically a case of keratoconus. Always remember that keratoconus always appears. A cone first comes on the back of the cornea, and later on it comes to the front surface of the cornea. So this is one of the patient. You can see the cone is very big size on the back, and a very small cone is there on the front surface. Other than this, the elevation map, the sagittal map, the Pentacam also gives you a Bellin Ambrosio enhanced ectasia display. This software takes two things into consideration. This is corneal thickness, spatial profile, and percentage thickness increase. Basically, it takes pachymetry value from the 22 concentric rings centered on the thinnest point. Then it calculates the rate of increase of the corneal thickness from the thinnest point, which is usually paracentral in keratoconus to the periphery. And remember that ectatic corneas, they thin at a faster rate when compared to the normal cornea. So let us look at this Pentacam map. On the left side, you see the cornea is very thin, 499. And on the right side, it is a thicker cornea, 536. But look at the maps. The black lines are the standard lines. The red line is the patient's line. If the red line falls drastically, suddenly down, that is abnormal. So the right side of the map, 536 thickness, is definitely is pointing that something is wrong there. While the left eye, even if the cornea is thin, it looks to be a normal cornea. So other than that, the pentacam will give you all this deviation of the back, the deviation of the front, the thickness, the deviation of the thinnest point. So these are also given at the bottom of the map. So these will also help in grading of the keratoconus. So now once we have diagnosed that the patient has keratoconus, what do we do? we can give glasses, contact lenses, or we can advise surgery. So remember that very young patients, up to young children and young adults, they progress very fast. So those are the cases you have to diagnose early, when even the signs and symptoms have not even come on the slit lamp. They always have allergies. Look for that. Look for sleep apnea, and you can manage with spectacles and soft contact lenses. Go ahead. And the thing which is lot of talk has been is on the corneal cross-linking. So basically, cross-linking was introduced by Theo Zeiler in 2003, and the aim is to increase the formation of cross-links between the collagen fibers in the stroma. So remember, we have three protocols: conventional, accelerated, and iontophoresis. Usually, conventional, remember that this was started earlier, where we removed the epithelium. We gave riboflavin drops every 2 minutes for around 30 minutes, and then we give the cornea, we expose the cornea for 30 minutes to the light. However, the UV light that was given was 370 nanometers at 3 millivolts per centimeter square. So this was the protocol which started, but a lot of patients had corneal scars and a lot of flattening was observed. So then most of our doctors, I think we are all now using accelerated cross-linking. In this, we use 9 milliwatts per centimeter square, and we irradiate the cornea only for 10 minutes. However, the total energy that is given to the cornea is the same. So we also have this already spoken. We have Athens protocol. So we can do topo-guided removal of the epithelium. Trick is nothing but we Schwind laser. When you use the Schwind laser machine, it removes the epithelium and it modulates the stroma in the same sitting. It doesn't use the PTK mode to remove the epithelium, and then again you use the excimer laser. So basically, this has been spoken. So basically, you are removing some microns of cornea over the thinnest epithelial thickness, and then you are remodulating the cornea to make it more even. And then excellent results already shown. So I will not be speaking much. So what are the surgeries? I'm sure Dr. Neha is going to talk. So DALC is for keratoconus cases. You remove the upper 2/3 of the cornea. You retain the endothelium, and that is DALC. If the patient is having a lot of corneal scarring, then of course you do penetrating keratoplasty. Just to mention CARES, already covered by Dr. Nivedita. This is created from the donor corneal tissue. We have all seen the video, and they are formed into ring, and it is inserted in the corneas, and we have seen that how it flattens the cornea. So let us come now to keratoglobus. This is a very rare congenital non-inflammatory disorder characterized by generalized extreme thinning and globular protrusion of the entire cornea. It has two very strong syndromic associations, osteogenic imperfecta and Ehlers-Danlos syndrome. They are connective tissue disorders, and they are associated with blue sclera. So osteogenesis imperfecta has fragile bones, deafness, easy bruising and bleeding. And the other one is associated with fragile skin, hyperextensible joint. So diagnosis of keratoconus, again, basically you can see it on the OCT. You have tomography. Here the thing is, in keratoconus, the cornea will be thin paracentrally. The peripheral cornea will be of nearly normal thickness, but in keratoglobus, you will have uniformly curved cornea with severe generalized thinning. So pachymetry usually shows reduced thickness less than 350 microns. So these are few of the features of the EDS. So differential diagnosis will be keratoconus, PMD, megalocornea, and congenital glaucoma. So what is the management? Conservative. You have to really protect the eyes. Medically, if there is a hydrops, hydrops means there is a perforation of the Descemet's membrane. So for any hydrops, either it is keratoglobus or keratoconus, you have to use topical steroids, cycloplegics, and lubricants. And surgical will be collagen cross-linking, CARES, large diameter penetrating keratoplasty, and epikeratoplasty. Again, I'm not going into the surgeries. The subsequent speakers are going to speak. So what is sphenoid marginal degeneration? This is an exam question. How to distinguish between PMD and other keratoconus mostly. So this is a bilateral, non-inflammatory peripheral corneal thinning disease characterized by a concentric band of thinning, usually always in the inferior cornea. Atypical presentations can be there. So many authors have definitely proposed that it is just a peripheral form of keratoconus. Now I'm just coming to the highlighted. How will you distinguish it from a keratoconus? So here the thinning is mostly inferiorly, and keratoconus usually stops at around 40 years of age, but this one continues to progress. There is no Fleischer's ring, no lipid deposits. So, and the maximum ectasia lies above the thinnest location, giving the cornea an appearance of bare belly. So, Vaux try, everything is there. There is no presence of Munson or Rizzuto's sign. Is very variable presentation. Usually, PMCD is usually found bilaterally. Unilateral cases have also been reported. Mostly, it has inferior thinning. You can see on the map there, and but atypical presentation where superior thinning has also been reported. So this is typical of the topography sagittal maps. You will have kissing dove, lobster claw, or mustache patterns. So butterfly-like pattern, this is very typical of PMD, pellucid marginal degeneration. Treatment again comes to contact lenses. You can give for the early cases, that is the RGP lenses, and cross-linking or tuck-in keratoplasty or crescentric lamellar keratoplasty. Remember, the thinning is mostly inferiorly. So this is my last slide. So how will you distinguish between keratoconus, pellucid marginal degeneration, and keratoglobus? So remember, keratoconus, the eyes are how common? It is quite common, keratoconus. PMD is rare and keratoglobus is very, very uncommon. Usually keratoconus starts early and then PMD comes from 20 to 40. Keratoglobus is always present at birth. Inferior paracentral thinning. In PMD, it is always inferior peripheral strip. Keratoglobus is global thinning. The cornea is protruded at the thinning, pellucid marginal degeneration, inferior thinning just above the limbus, and the cornea is more steep above the thinning. Keratoglobus is always global. Fleischer's ring is present, sometimes present in PMD and not present in keratoglobus. Spontaneous rupture is very rare in the first two, but very common in keratoglobus, and Munson sign can be seen. So to summarize, early management of ectasia is essential to prevent its progression and to preserve visual potential. The future of full visual rehabilitation for corneal ectatic disorders may lie in combination of the treatments focused on addressing both the structural and refractive issue. The most promising options include combining intracorneal ring segment with cross-linking and cross-linking combined with advanced excimer laser ablation profiles. Thank you so much for your kind attention.
Thank you so much. The next speaker is Dr. Nidhi Gatkar Kashyap, and I request you to finish it on time. The time is 10 minutes. All the speakers are crossing the time, and because it is already 9:30. So please be precise and finish it in 10 minutes. Over to Dr. Nidhi.
Good evening, everyone. Is my screen visible?
Yes.
Okay, so I would be talking about a much practical topic, which is corneal tear repair. And after doing corneal tears over the years, I feel that every corneal tear is different. But if we follow the principles properly, we may be able to give the best outcome to the patient, at least from our side, irrespective of the type of injury. So when we talk about corneal tear, it involves repair of the tear, management of the iris prolapse, lens management, and also management of the complications. So according to the best trauma system, this is the way that the classification is done, and it helps us to decide and prognosticate the case, and also helps to counsel the patient according to the site and zone and the type of rupture of the open globe, and also we look at the pupil and the vision. So this is more for prognostication of the case. So challenges in repairing the corneal wounds is that the wounds might be irregular, the tissue is edematous, there might be tissue loss, there might be prolapse of intraocular contents, and the globe might be hypotonous. So the goals is to manage and ensure a watertight Ensure a watertight globe and maintain globe integrity and normal intraocular pressure. Remove the contaminated and non-viable tissue and any foreign body if present. Reposit the viable tissue and avoid any iatrogenic damage and restore the visual function. First thing is to differentiate if the patient has infection or inflammation. So many a times when we see such cases, when there is an iris prolapse, there might be an infection or there might be a lot of inflammation as well. So you need to differentiate this, because post-operatively when you're giving steroids, if there is a suspected infection, the steroids will actually flare up the infection. So that needs to be ruled out before steroids are given post-operatively. Also, look out for any intraocular foreign body or any embedded foreign body which needs to be removed before the tear is repaired. To corneal lacerations, these might be partial thickness or full thickness. So whenever you have a partial thickness laceration, it is important to always do a Seedles and force Seedles test to rule out any leak, because if there is a leak, then suturing needs to be done and any conservative management will not work. If the wound is self-sealed and Seedles is negative and it is less than 2 millimeter, then a conservative management can be done, a bandage contact lens can be given. But if it is more than 2 millimeter, then a glue BCL can be done in such cases. When we have lacerations with flaps, if the laceration is opposed and undisplaced, then a BCL can be given. And if the laceration is displaced, then we have to do partial thickness suturing. If you look at this case, this is a partial thickness corneal tear where there's a very large flap. So first of all, you need to clean the interface of all the debris, else they will get embedded in the interface and later on cause an infection. And then suturing here needs to be tight, because if you see the flap, it shows some kind of infection as well, and it looks very edematous. So only when the flap is very tightly sutured to the bed, that is when the stromal edema will go down over time. So this is an example of a tear which is lamellar and there is no displacement, and it could be treated only with a bandage contact lens. However, when you see significant displacement, at that point suturing has to be done for proper opposition of the surface, and then only the epithelium will grow over the tear. And whenever you see any other type of lamellar tears, you need to clear the interface of debris. Sometimes when the patient comes to you after a couple of days with a lamellar tear, actually epithelial thinning, healing might have just be. But when you look at the interface, debris might be present. So here you have to again remove the epithelium, freshen out the tear, and then now, if the laceration is simple, just do a suturing. If there is uveal incarceration, then you can reposit the tissue or abscise. Now, what is the difference between excision and abscission? Excision is just removing the tissue which is out. But when we abscise, we also take out some of the healthy tissue so that we know that the dead tissue has been completely removed. So whenever there is an iris prolapse and you feel that it needs to be removed, then you have to not excise but abscise the tissue. If the patient has lens involvement, then lensectomy needs to be done. If vitreous involvement is there, vitrectomy needs to be done. Scleral involvement, scleral suturing needs to be done. And if there is a tissue loss, then a patch graft or a keratoplasty might be required. To the choice of anesthesia, again, topical or local anesthesia is suitable only for small and anterior defects, because while giving these blocks, there is an increase in the intraorbital and intraocular pressure, which can cause expulsion of contents. So general anesthesia is preferred because it gives excellent anesthesia and echinacea, and also does not increase the intraocular or intraorbital pressure. Coming to the goals of corneal suturing, you have to make the wound watertight, reconstruction of the native non-astigmatic contour, minimal scarring of the central cornea, avoidance of tissue override and post-operative edema, and prevent late complications. So coming to suturing, first is very important to identify the anatomical landmarks, and we need to preserve the anatomy as much as possible. So if we have to secure the landmark, if you see a limbus to limbus tear, the first suture needs to be placed at the limbus so that you know how the anatomy of the cornea is. Now, the preferred suture will be always a 10-0 monofilament nylon, non-absorbable. The needle is sharp and it is a spatulated design. And the thickness of the corneal suture should be 90 to 95% of depth through the stroma. Ideal length is around 1.5 mm, and it should be equal depth on each sides. And you have to take 3 throws. It can be 3-1 or 3-1-1, whichever you feel comfortable. Suture bites through visual axis should be avoided or minimized. Smaller bites in visual axis, the knot should be buried away from the visual axis, and the knot, whenever you bury it, it should not be in the wound, else it can cause a wound gape. So we try to do a no-touch technique, especially if the tissue is edematous and it is possible to not touch the wound. But if you have to, then also you have to take care that you cause minimal trauma to the edematous tissue. To rule of halves, whenever we have a large tear, we have to progressively halve the wound. So if you have a tear, first suture you'll take at the center and halfen the tear. Then you will take the other quadrant and halfen it, the other quadrant and halfen it, and then take sutures in between. That way you will have equidistant sutures and the wound will be watertight. Whenever you have straight wounds, straight cut wounds, which are vertical, then it is okay to have the entry and exit point equidistant. But if you make it irregular or the distance is not equal, then after you tie the suture, there will be a tissue override, which will again prevent proper healing and cause a lot of astigmatism. However, we usually see a lot of shelved lacerations. These are angular cuts. And here, if you keep the upper part equal, then again there will be a tissue override. So in these cases, you have to see that the suture which is passed, so the posterior part of the suture, it should be equal. So here if you see, the chord C and D is equal. You don't have to keep A and B equal. You have to keep C and D equal, and then you will have a proper watertight wound. Coming to the distance between sutures, now every suture, the suture length, it exerts a diamond-shaped area of compression. So in between sutures, the space which should be there should be such that the area, the diamond area, should overlap. Now, it should not be too close, as it will cause more scarring and higher irregular astigmatism. And it should be not too far also, because then there will be wound gape and wound leak. So the ideal situation will be this or a little overlap of both the rhomboids here. Now, this is a technique called Rose-Hayes technique. If you know that the normal cornea is prolate shaped, that means it is flatter in the periphery and steeper in the center. So after you have a corneal tear, which is large enough to involve both the limbus, that time the whole architecture of the cornea is lost, and you need to regenerate it to preserve the normal contour and prevent too much of astigmatism. So whenever we take sutures in the periphery, we have to take longer bites, which cause compression. And whenever we take sutures near the pupillary axis, they have to be shorter so that they do not cause too much of flattening. So longer in the periphery, shorter in the center, as minimum as possible in the pupillary axis. And distance should be such that the rhomboids should overlap, should not be too far, or should not overlap too much, should not be very close together. Coming to angular corneal wounds, now these can be a little difficult. So the initial suture should be placed at the angle of the laceration. And suturing should be done from the angle and not towards it. So first you have to close this area, and then you can close from the other sides. When we have very ragged type of corneal tears, then what you do is you take the initial sutures at the angular areas. Like here you take 1 and then you take 2. And therefore, then you get a proper contour, and then the intervening areas can be sutured very nicely. Many times we will have irradiate or stellate corneal lacerations, and here these are treated as multiple flap tears. Now, what happens here is the center, though it is showing very regularly here, it is not that regular, and the edges are very, very edematous. So every area should be treated as a different flap tears. And then after suturing, sometimes we have to take longer sutures as well to bridge the center apex of the corneal tear. So this is how a tear is. If you look at the center, you have to take a longer bridging suture which covers the apex, because it does not usually look so textbook. The tissue is quite edematous. So if you do not suture this area, it will keep on leaking and the AC will not form. So that needs to be taken care of. Another method here is Einer method. Here, when we have different type, they have told is you make a partial thickness incision with a diamond knife, and then you pass a running suture and then close it like a purse string. But what happens is all this area is very, very edematous. Making a partial thickness incision here becomes quite difficult. So actually this Aiken's method is more preferable. Only if you have a very fresh tear and very strong non-edematous edges, that is where you can try this method. Now, corneal tears will be obviously accompanied by scleral lacerations also. So here, what you need to do is, first you need to do a peritomy and see the extent of the scleral tear. Never leave a scleral tear where you cannot see the posterior most end. And whenever you have a combined tear like this, the golden rule is to first take the suture at the limbus, then do the corneal suturing and do the scleral suturing. And scleral suturing is you keep on suturing as you go posteriorly. So scleral suturing will be done with absorbable suture. It can be 60 or 70 Vicryl. Here the indented depth will be around 80%, and make sure that you do not pass the suture through the choroid or the uveal tissue, else it will cause a lot of bleeding, and there is a chance of sympathetic ophthalmitis as well. If the scleral tear is going beyond the recti and you cannot see the posterior most part, then sometimes you have to hook the muscle and then retract it to see the posterior most extent. And sometimes you also need to disinsert it, repair the tear, and then reinsert it. That is also done many a times. So a few tips again. Always make a side port incision to form the AC, and do not manipulate the corneal wound. And repair the globe first, followed by any other adnexal injuries. Prolapsed uveal tissue should be abscised, and reposition of the uveal tissue should be done with sweeping movements from the side port. Do not try to stuff the uveal tissue from the tear inside. Remove the epithelial growth over the uveal tissue before repositioning it, and avoid incarceration. So many a times what happens is patient comes after 3-4 days with a uveal prolapse, but you see that a whitish membrane has formed over it. So this is the epithelium which has grown. Now, if you try to deposit the uveal tissue here, it will not go inside, and if you go, then there is chances of epithelial ingrowth. So you need to peel off that epithelium and then deposit the tissue. And if you have any vitreous which is prolapsed, you need to cut it flush to the laceration. Now, this is a complex tear in which there is some vitreous prolapse as well, and a vitrectomy was not available at that time. So first the vitreous was cut flush to the laceration, and then a pars plana port was made and the vitrectomy was completed. Prolapsed iris, preserve the tissue as much as possible.
Dr. Nidhi, can you finish? Yeah, please.
Yes,
Fast,
24 to 36 hours is the maximum safe period to deposit the tissue. In apparently or visibly infective corneal lacerations, do not deposit the prolapsed tissue. If prolapsed iris is necrotic, do not deposit it. So this is an example of devitalized tissue, better to abscise. And the second one is the tissue. It was a pretty recent tear and tissue was viable. So here it was reposited. Again, management of lens matter. Again, lens aspiration in the primary setting has to be done if the capsule is ruptured, in which the vitreous is involved with lens remnants, and if we need to do a posterior segment surgery and the lens is cataractous and surgical visualization is not good. In other cases, elective cataract surgery can be planned as a second stage procedure. Now, in some cases, if there is tissue loss, you need to do a glue plus BCL. In amniotic membrane transplant, you can do a donor patch graft, or you can do a Gunderson flap or a pedicled conjunctival flap. Just showing this case where the case was completed nicely, but there was a persistent leak and there was a tissue defect. Here, a glue was put over the sutures, which helped to seal the wound, and then it was removed at an earlier date. When to remove sutures? If loose, remove immediately. If there is vascularization of the wound, it is an indication for removal. Pediatric patient to be removed faster as they have better wound healing. And if there are very large tears, it can be done in a staged manner. Again, post-operative management needs to be taken care for infection, glaucoma. You need to give cycloplegia for pain relief, lubricants, steroids. Again, long-term rehabilitation needs to be done as keratoplasty, as endothelial keratoplasty with contact lenses or spectacles or low vision aids. Thank you.
Thank you, Dr. Nidhi. Now I invite Dr. Seema to present on corneal ulcers. Thank you so much. Please share your slides, Dr. Seema.
Am I audible?
Yes, yes.
Yes. And my share is visible. Slides are visible now?
No, no.
It's not visible. Okay. Is it visible?
Yes, yes. Please start.
Okay. So, a very good evening to one and all. And I'll be dealing with approaching corneal ulcers, diagnosis, microbiology, and treatment. So as you all know, that corneal ulcer is an ocular emergency, and it is characterized by epithelial defect with some amount of stromal involvement, either due to infection, trauma, or inflammation. So it presents a significant risk to vision loss, and due to its devastating complications, it needs a very prompt and early recognition and treatment. So how to approach a case of corneal ulcer? So we have to lay a lot of emphasis on history taking, because each and every ulcer has its own pathognomic signatures. So evaluation of the risk factor is another very important thing that needs to be taken care of. Thorough clinical examination is a must, and understanding diagnostics and microbiological evaluation is equally critical. So there are a lot of diagnostic adjuncts beyond these microbiological evaluation, which you should know. And also the documentation and color coding is very, very important, because this documentation not only helps in assessment of the corneal ulcers, it also helps in looking for the follow-up treatments, whether the ulcer is healing or not. So, and then the initial empirical treatment strategies are important. So in the clinical approach, a thorough history is very, very important. So most important history would be of trauma, whether it is from a vegetative matter indicating a fungal involvement, or a metallic foreign body for a bacterial involvement. Contact lens history is very, very important, although it's not very common in India, but in Southeast Asian regions. But here, it poses a risk of pseudomonas and acanthamoeba. So previous corneal surgery histories is very important. Any cataract surgery, any corneal refractive surgeries like in LASIK, generally the flap is contaminated by that atypical mycobacterial infections. So any prior ocular disease like herpes simplex disease or dry eyes, or any condition that is actually contaminating the ocular surface, like chronic dicryocystitis, exophthalmos ectropia, or trichosis leucophthalmos, any of these factors you need to check for proper healing of the ulcer and to diagnose the case. A lot of systemic factors need to be taken into consideration, whether the patient is having diabetes mellitus, immunosuppression, or or autoimmune diseases, whether the patient is a HIV positive patient, and also the presentation of patient, whether it is acute or chronic presentation. And the medication history is definitely very important, where topical steroids and immunosuppressants are very important, whether the patient is on ATT or not. So coming to the comprehensive slit lamp examination, this is very, very important. Here, the epithelial defect needs to be taken into account. The size and shape and depth should be measured. The stromal infiltrates, the size, density, and location is very, very important, and the color also. Corneal edema surrounding and underlying the ulcer is important. Any impending perforation of the cornea or extreme thinning of the cornea needs to be taken into account, and anterior chamber reactions like cells and flare and hypopyon should be looked for. Descemet's fold generally indicates a deep stromal involvement, so it's very important to evaluate the different layers of the cornea. Conjunctival injection pattern and severity is very, very important, because generally you obviously encounter a circumciliary congestion in cases of corneal ulcers. So the discharge quality is also very important. The mucopurulent, the color is also very important. So all these things needs to be evaluated. So the type of ulcer is very important, whether it is non-infectious ulcer or an infectious ulcer, because the treatment strategies are going to change. So what we are frequently encountering in our OPDs is the infectious ulcers. So I'll talk a bit in a detail about these infectious ulcers like bacterial, viral, fungal, and pitosuval. In the bacterial ulcers, generally you see that the epithelial defect size typically matches or is smaller than the underlying stromal infiltrates, and there will be dense suppurative gray white infiltrates with well-defined margins. Mucopurulent or purulent discharge very much seen in the Neisseria gonorrhea infections. Anterior chamber reactions with hypopyon is very common in severe diseases, and generally bacterial diseases like Staph aureus, they have a very rapid progression in first 24 to 48 hours, but they do respond to treatment very nicely. But with Pseudomonas aeruginosa, they are very fulminant and tend to grow very fast, and they cause a lot of thinning, and surgery over here, like therapy to keratoplasty, becomes a must. In the viral keratitis, herpes simplex virus is the predominant one. And the classic presentation is the dendritic lesion with terminal buds and the epithelial keratitis. So geographic and amoeboid ulcers can occur when these dendrites are coalescing. Very important to distinguish between these two dendrites and the pseudodendrites that you find in the herpes zoster virus infection and all the fungal infections. So we have to differentiate between both of them. Many a times you can see immune rings and stromal keratitis without an epithelial defect also. So in viral keratitis, it is very important that you elicit the decreased corneal sensations. And here in viral keratitis, you see a lot, the eye is very much symptomatic, signs are very less. And associated skin lesions like eyelid blisters must be looked for. The intraocular pressure needs to maybe elevated, and this needs to be taken care of. In the fungal corneal ulcers, very important, because here the history of vegetative origin is very, very important. Mostly patients who are coming from with fungal ulcers, they are from the agricultural background. Also you need to find about the history of immunosuppression, whether the patient has already had is on topical steroids, or he has recently been admitted or hospitalized, or because there are chances of nosocomial infections over there. So Physarum and Aspergillus species are very common in our region. Slower progression and it has a very slow progression as if you compare it with the bacterial corneal ulcers. And it's more common in tropical climates, as the fungus loves hot and humid climate. So feathery irregular margins is pathognomic of the fungal corneal ulcers. It has a dry elevated surface and satellite lesions surrounding the main infiltrates. You'll see a lot of gray-white infiltrates with rough dry surface is characteristic, and immune rings can be seen. Pigmentation is the hallmark of fungal corneal ulcers, and there is very slow progression if you compare it with the bacterial corneal ulcers. Here, the patient will be he will be having a lot of signs, but very few symptoms. So this is important. Very much similar to the fungal corneal ulcers, you have the protozal infections like with acanthamoeba keratitis, but here the difference is that the patient will have severe disproportionate pain, and this is the hallmark because of the radial keratoneuritis or the inflamed corneal nerves. And also there will be presence of perineural infiltrates, and it will have an indolent course over weeks. So contact lens history over here is very important, although it's not common in our region, but and contamination of with soil or which is vegetative matter is quite common. So next comes the documentation of the ulcer, which is very, very important for the PG students. They need to draw diagrams of the ulcer. Now, this documentation is not only important for the assessment part, it's also important for your future follow-ups when the patient is coming in the follow-ups, and you need to assess the treatment, the response to treatment that you have given. So whether the ulcer is healing or not, that documentation is very important. You can also opt for slit lamp photography in these cases. So coming to the microbiology part, indications of corneal smear and culture will be a large central corneal infiltrate with stromal involvement, chronic and unresponsive infection, atypical clinical features if present are then you can go for it. Then previous corneal surgeries and multiple infiltrates. So these are the equipments that you require for microbiological evaluation. And this is you need a Cumura spatula for corneal scraping. You can also opt for a 15-number disposable blade and 2 glass slides, one for KOH and one for GIMSA. So these are the prerequisites. Now, one thing that is very important, if you have microbiological support, one test that you want to do is gram staining, because gram staining will help you to decipher the bacteria and fungus as well. But if you don't have a microbiological support at your side, then one test that you must do is the 10% KOH. Now, KOH pellets are easily available in the chemist labs, and you can easily make it with the help of the distilled water, and you can look for the ulcers. And KOH also helps in deciphering the acanthamoeba species. So one important thing that prior to doing the corneal scraping, you need to discontinue the medical therapy at least for 12 hours and 24 hours, if not possible, then 12 hours definitely. And these are the optional media, like atypical cases, Lowenstein-Jensen media for the atypical mycobacteria you can do. So apart from microbiological evaluation, we have a lot of diagnostic adjuncts like the fluorescence staining that is easily available to us. And then the anterior segmentosity, this is very important because it helps to assess the ulcer depth and the stromal involvement. It's a non-contact technique which will help you to, is very much ideal for the fragile corneas at perforation risk, and helps to visualize the Descemet's membrane integrity and the anterior chamber depth. So it's also important for monitoring descemetocele and planning the surgical intervention on time. In vivo confocal microscopy is another very good tool which gives the morphological evaluation of all the layers of the cornea. But one deficit is there, that it cannot identify the bacteria because of its small size. So a lot of systemic investigations also you need to do in case of corneal ulcers like PCR, FT, ABS, for interstitial patterns and all those tuberculosis, viral markers, blood sugar, HIV status, you need to know. So how to start the initial empirical treatment strategies. So for that, for the bacterial, we opt for the fortified antibiotic preparations, fortified cefazolin, vancomycin, and tobramycin. And these, once constituted, they can be stored in the refrigerator at 2 to 8 degrees of centigrade, and they are stable for 7 to 14 days. And the benefit is that the concentration is 5 to 10 times much higher than the commercially available preparations. And apart from that, you also need to add some cycloplegics like cyclopentolate or atropine, because they are going to relieve the ciliary spasm and also stabilize the blood aqueous barrier and prevent the stereocyanic formation. So intraocular pressure, definitely you should use the beta blockers, but please try to avoid the prostaglandin analogs, which will indeed increase the inflammation. So artificial tears also you can use. So steroids for corneal ulcer trial, this actually demonstrates no benefit and possible harm with early steroids used in bacterial keratitis. So the current recommendation is to avoid steroids until the infection is controlled, at least for 48 to 72 hours, improving clinical course and organism sensitivity is confirmed. Now, in the viral keratitis, you have the herpetic eye disease study, where this is a series of prospective randomized clinical trial divided in 3 therapeutic, 2 prophylactic, and 1 COVID trial. And here, the head's stromal keratitis not on steroid showed that topical steroid actually reduced the progression of stromal keratitis. And head's stromal keratitis on steroid it showed that adding oral acyclovir to the treatment regime of topical steroid and topical antiviral, it doesn't benefit the visual outcome and time of resolution. And then the herpes simplex virus iridocyclitis receiving topical steroids. Here it was seen that adding oral acyclovir can be beneficial in HSV iridocyclitis receiving the topical steroid and antiviral, but the effect was seen after 3 weeks. In HEADS 2, we have the acyclovir prevention trial, and it showed that prophylactic use of oral acyclovir reduced the recurrence of any form of ocular HSV infection. And HEADS epithelial keratitis trial, it showed that no benefit of preventing the progression of stromal keratitis or iridocyclitis with oral cyclovir. So the third one was the HEADS recurrence factor study, and where it showed that factors like stress, UV exposure, contact lens user are unlikely to trigger the recurrence of ocular HSV infection. Now, TST protocol has already been nicely discussed by Dr. Praful. So a little bit, just a revision. Natamycin still 5%. It is still the gold standard. If poor response, please add topical voriconazole. You can add systemic therapy for ulcers greater than 5 mm, deep ulcers or impending perforation. You can add oral ketoconazole or voriconazole. And the targeted therapy for resistant cases, poor response, we can give intrastromal or intracameral injections of antifungals, and surgical intervention wherever there is severe thinning, there is impending perforation. Whenever the lesion is approaching the limbus, you can always go for therapeutic penetrating keratoplasty as it is therapeutic as well as gives the tectonic support to the eye. So in the mycotic ulcer treatment MUDS trial, it was seen that topical natamycin is more effective than topical voriconazole for filamentous fungi keratitis. And in MUDS 2, it has been shown that no significant benefit of adding oral voriconazole to topical therapy for general treatment of the filamentous fungus ulcers. So in the protozoal ulcers, here the debridement you can go for, although there is no specific agent to treat these protozoal infection, but still polyhexamethylene biguanides, hexamidine, and propamidine can be added, and topical neomycin 0.3% can be given. Now, there are a lot of potential complications. So, permanent corneal scarring with visual impairment can occur. Corneal perforation, they require an urgent surgical intervention in form of therapeutic penetrating keratoplasty. Now, secondary glaucomas for inflammatory changes, they are one of the most important indications where you actually have to intervene surgically. Also, in cases of cataract formation, if there is intense anterior and posterior synechia development or endophthalmitis in severe cases, we need to intervene. So these are the pictures, some of the pictures of these complications. So according to the complications, you have to intervene, give treatment. Like if there is a perforation of smaller size, you can go for tissue adhesive glues like cyanoacrylate glue. Go on for rigid contact lenses. If the perforation is large, you can go for a corneal patch graft, and visual rehabilitation by therapeutic keratoplasty and later optical keratoplasty can be done. So the take-home message is corneal ulcers, they represent a true ophthalmic emergency, and we need a comprehensive history and examination guides the diagnosis, because each and every ulcer has a very pathognomic signature. So you have to understand that pathognomic signature in order to reach the diagnosis and make a treatment decision. So microbiological workup is the cornerstone of management, very important, and should be started in each and every institute and should be done by all the postgraduate students. So empirical therapy you should start immediately post scraping, and it is important to recognize the non-bacterial etiologies because the treatment strategies are going to change. If you don't realize them, you will end up doing wrong treatments and further worsening the ulcers. So emerging modalities like collagen cross-linking and may expand the therapeutic options, and prevention through education reduces the disease burden. This is very, very important. So patient counseling is very, very important for reducing this burden. Thank you.
Thank you, Dr. Seema. You have covered a very vast topic in very appropriate time. Just a quick question. What do you do when you see a suspected patient of acanthamoeba keratitis? Do you have any drops over here? Or do you prepare them here?
We don't have that pharmacology for specially preparing them, but all those azithromycin we give. Azithromycin we are giving because neomycin 0.3% again can be given. We try to procure it. ESI, we get those things from ESI because they have that, possibility of acquiring the antibiotics from it. So many of the things like mitomycin and all, we are trying to procure from the ESI part.
Okay, because I believe PHMB drops are being given by LV Prasad.
Yes.
So, but this is the problem here that we don't get all these drops.
PHMB आई ड्रॉप चलाते थे पहले PHMB, बट अभी मिलता नहीं है.
मैम कहाँ से मिलता है? यहाँ पे मिलता है?
अभी नहीं मिलता है. पहले हम लोग करते थे, हमको याद बात नहीं है, लेकिन मेरे हम लोग करते थे PHMB.
Thank you, ma'am. Thank you.
हाँ.
So now the next speaker is thanks, Dr. Seema.
Thank you, ma'am.
Yeah.
I just stop here.
Yeah. Dr. Neha will now be speaking on the surgery part of the corneal transplants. Dr. Neha, please come forward and present you.
Yes, ma'am. Just 1 minute. I'll be sharing my screen. My screen, is my screen
Yes. It's coming. Yes.
Yeah.
Go on the slide mode, please.
Yeah. Very good evening to all. I'll be speaking upon keratoplasty tonight. And first of all, I would like to tell what is keratoplasty, or what is called as corneal transplantation. It is a surgical procedure to replace a diseased or a damaged cornea with a healthy donor cornea. The purpose might be to improve vision or the structural integrity, or both, depending upon the specific condition. Before jumping upon the types of the transplants, I would like to tell that cornea is a transparent and an avascular structure which comprises of 6 layers: the epithelium, which contains the wing-shaped squamous cells. Then second is the Bowman's layer. Then the stroma, which is the major part of the cornea. The Duas layer, which is around 10 to 15 microns. The Descemet's layer, which gives a layer for endothelium to rest. To start with corneal transplantation, the history says that Himley was the first person who had given the concept of corneal transplantation. Von Hippel was the first person who actually did a first transplant in 1886 by replacing a diseased human cornea with that of a rabbit cornea. And then Fuchs came. He did a first lamellar corneal transplantation, which was not accepted well because of the poor outcomes in terms of visual quality. The first successful corneal transplantation was done by Zim in 1905. So corneal transplantation can be divided as full thickness transplant, that is penetrating keratoplasty, and the lamellar ones, that is the anterior and the posterior. So full thickness transplant is based upon the divided as optical penetrating keratoplasty, therapeutic penetrating keratoplasty, tectonic, and cosmetic. Optical is to restore vision, therapeutic is for treating infective keratitis, tectonic is to maintain the globe integrity, and cosmetic, when the patient has a blind eye, just for the cosmesis, the transplant is done. So penetrating is done when the opacity is involving full thickness and the endothelium is also poor. And the other is selective. Selective can be anterior selective, which is superficial anterior lamellar keratoplasty, ALTK, and deep anterior lamellar keratoplasty. And selective posterior is Descemet stripping endothelial keratoplasty, either manual or automated, and Descemet membrane endothelial keratoplasty. I would be briefly discussing about the steps of transplants. That is, first I'll be discussing about penetrating keratoplasty. The initial step and initial procedure, what is done prior to taking the patient for penetrating keratoplasty. Patient is advised for IV mannitol, and the pressure of the eye has to be lowered. Either the surgery is done under local anesthesia or general anesthesia, depending upon the case scenario. First, trephination of the donor tissue. How it is done? The donor graft disparity is to be taken as 0.5 mm oversized graft for the routine cases. In cases where keratoconus cases is there and you want penetrating keratoplasty to be planned, 0.25 mm or same corneal size is taken. And we use either handheld refines or punched refines are also available. Barren vacuum refines are also available. So for the diameter of the recipient bed, 9 mm or more, the 9 mm or smaller than 7 mm, the graft should be larger than the host by 1 mm. If the diameter of the recipient is between 7 and 9 mm and the eye is aphakic, the graft should be larger than 0.5 mm. However, if the eye is pseudophakic or phakic, the graft should be 0.25 or larger than the host. When the recipient bed of 7.5 mm, the 0.5 mm oversized graft is taken, which induces a myopia of 4 diopters, and with 8 mm, it causes an oversizing of 0.5 oversized graft is taken, and it induces a myopia of 2.5 diopters. Marking of the host cornea is done with the radial marker. Then trephination of the host cornea is done about 90% of the depth, and cornea is thoroughly dried before trephining. It is done either in a rotation manner between the thumb and the forefinger, maintaining a downward pressure. 90% depth of trephination is done to avoid damage to the iris, lens, and sudden AC collapse. MVR blade entry is done into the AC for cut and to initiate the cutting either with the corneal universal scissor or the right and left hand scissors. This is a picture depicting how the trephination, like the host cornea is trephined and removed. After the trephination, the donor is secured over the host cornea with like sutures are started. The first and the second sutures are most important. The first 4 sutures are called the cardinal sutures, and this only decides how the tension of the other sutures will be. After placing the 4 cardinal sutures, the appearance of the segment looks like a diamond or a square shape. Now, the technique of suturing can be either single interrupted sutures or combined continuous and interrupted sutures. The single continuous sutures technique involves the torque pattern, the anti-torque pattern, and no torque pattern. The torque pattern rotates the cornea in a counterclockwise form at the wound or at 11 degrees. The anti-torque pattern rotates the cornea clockwise by 0.7 mm at the clocker and 11 degrees clocker. Then no torque when the bites of which form an isosceles triangle producing no rotational effect. And then the other is the double continuous suturing technique can also be used. Most of the surgeons usually prefer doing interrupted sutures, and interrupted sutures are recommended in infants and children, and especially in cases of highly vascularized cornea and in therapeutic keratoplasty. The advantage is that there is like while suture removal, you can do a selective suture removal. The needle in suture removal should pass anterior to the descemet membrane, and the suture length should be about 2 mm, 1 mm on each side. The full thickness suture should not be put as these cause endothelial trauma and aqueous leak, and high chance of infection can also occur. Some surgeons bury the knot in the host side, but I prefer to bury the knot in the donor side, because if we bury the knot on the recipient side, there may be stimulation of vascularization and graft rejection. Then this is a video showing penetrating keratoplasty steps. substance is injected.
We are not able to see the video.
Okay, ma'am. Okay. Okay. Okay, ma'am. I don't know.
think you can try coming in the last. You finish your presentation. Yeah.
Okay, okay. I'm not able to like share the video. Okay. So I'll be coming
full
to
screen. Go full screen. Yeah.
Yeah, is it now full screen?
Yes, yes, yes.
Yeah. Then coming to deep anterior lamellar keratoplasty, the indications being when the anterior stroma, mid stroma is involved and your endothelium is normal, like the degenerations and the ectasias, then post-LASIK ectasia, corneal scars, stromal dystrophy. Then in cases of ocular surface reconstruction and infections also, anterior lamellar keratoplasty can be used. So anterior lamellar keratoplasty is basically like can be divided as superficial and deep. In the superficial anterior lamellar keratoplasty, where anterior 30 to 50% of cornea is removed. Stroma to stroma interface can degrade the visual acuity in SALK. Usually, it has been seen in some of the studies. Then deep anterior lamellar keratoplasty, where the corneal stroma is completely excised up to the Descemet's membrane, and stroma to Descemet's interface provides a high quality of vision. So deep anterior lamellar keratoplasty is like mainly two types, basically described as descemetic dark and pre-descemetic dark. Descemetic dark is when the total stroma is replaced down to the DM, and pre-descemetic where failed attempts to attain the DM barring. That is, it can be divided as type 1 big bubble and type 2 big bubble that is achieved. In type 1 big bubble, the bubble is attained between the stroma and the Duas layer. It is a well circumscribed bubble that is achieved. It is around 8.5 mm, and the bubble appears clear like white thing, and the bubble starts from center and it moves towards the periphery. This is the bubble that most of the corneal surgeons prefer to achieve in the dark surgery. Then type 2 bubble is between the Duas layer and the Descemet's layer. It is very thin walled. The bubble size is 10.5 millimeter. It is like a clear bubble, and it starts from periphery and then comes to the center. In dark, there are various techniques have been described in history. The first that was described was by Anwar, that was in 1974. That is deep anterior lamellar dissection in potential space between the stroma and DM. Then by Archila, he used intrastromal air injection for dissection. Then Sujita et al. Described hydrodelamination and spatula delamination. Then Subota et al. Described divide and conquer technique in 2 layers. And then Melis described the limbal approach to deep anterior lamellar keratoplasty. So basically, the most people prefer doing Anwar big bubble technique, in which first the partial trephination, a groove is made in the periphery of the cornea, like around 8.5 mm trephination is done. Then after trephination and debulking anterior, like around 20 to 30% of the stroma, a 27 or a 30 gauge needle is attached to the air fill, which is bent at 30 to 40 degrees, and the bevel is facing down, and that air is injected into into the stroma at 80% depth through trephine groove and advanced into the paracentral region. Then air is injected in a slow fashion. Before injecting air, a paracentesis port is created in the AC so that there is no sudden burst of the DM. That air is injected inside, and the end point is seen when the border of the bubble coincides with the trephine incision. So this is a technique. First, there is formation of the big bubble. Then keratectomy of the anterior and anterior to the bubble is done. Then we see the bubble after keratectomy, and limbal paracentesis is done away from the peripheral edge of the big bubble. Then the bubble is punctured, and that is a brave slash is given in the bubble, and then the 11 number blade is immediately removed. The air collapses from the side. Side visco is inserted, and a spatula is inserted inside the groove that is made, and then the residual stroma is excised along the trifine cut in a 4-quadrant fashion that is seen in this image. Then the other technique which aids in the Anwar big bubble technique is the double big bubble technique, where a small air is injected into the anterior chamber. First, the air is injected in the AC, and the second bubble is attached, that is in the stroma that we give. So endpoint is that is sudden peripheral movement of the air bubble into the anterior chamber, which confirms that the when we rotate the eyeball in all directions, that the DM in the central bulges in the AC, and a small bubble in the AC will be confined in the periphery. Then how to prepare the donor tissue? The donor tissue, the desmids and endothelium are removed in toto from the donor tissue. It is stained with the trypan blue 0.06%, is applied to the DM. It is removed with the dry Vexel sponge, which is used to detach the DM from the periphery, and then it is gently scraped off. And we hold the tissue with the non-tooth forceps while peeling off the tissue. Then that can be done either with microkeratome or femtosecond laser also, which has more precise, like more good results are seen with microkeratome and femtosecond laser. I won't be able to show the videos. It is not being played properly. I don't know somehow. Then when we compare deep anterior lamellar keratoplasty with penetrating keratoplasty, deep anterior lamellar keratoplasty has advantage that there is reduced risk of rejection, there is preservation of the host endothelium, faster rehabilitation, and possibly less astigmatism as compared to penetrating keratoplasty. Now coming to posterior lamellar keratoplasty, which was first described by Gerrit Mellis. He said that replacement of diseased posterior corneal layers and endothelium with donor corneal tissue, the host anterior corneal stroma is retained. When there is dysfunctional host endothelium and there will be regression of the epithelium, there will be more of edema. But when you replace it with a healthy donor tissue, there will be regression of the epithelial and stromal edema when the endothelium starts functioning back properly. Posterior lamellar keratoplasty was described by Price et al. He introduced DSEC, and that was manual one. Then Gorovoy described the automated DSEC, and then Mellis described DMEC, which is the most advanced, and the recently people are shifting to DMEC. The goal of endothelial transplant surgery is that a smooth surface topography is achieved without significant change in astigmatism from preoperative to postoperative status, a healthy donor endothelium that resolves all the edema, a tectonically stable globe and safe from injury and infection is achieved, and optically pure cornea can be received, and a surgical technique that is quick and easily acquired. So DSEC, it is indicated in cases where there is endothelial dysfunction, the cases where there is Fuchs endothelial dystrophy, pseudophakic bullous keratopathy, aphakic bullous keratopathy, failed graft, iridocorneal endothelial syndrome, or when shed is there. So DSEC surgical steps include a scleral or a corneal tunnel incision is made to enter the anterior chamber, and a paracentesis port is created. Then a 7 to 8 mm mark is made using a trifine on the cornea, which helps to guide the desmetorexis. Desmetorexis is performed using a reverse Sinskey hook. This process can be assisted by improving the visibility by using air or trypan blue or chandelier illumination. When phacoemulsification is to be done, first the phacoemulsification is completed and then desmetorexis is performed. Having scored the desmids membrane, the diseased desmid membrane can be peeled off using the forceps or desmid stripper, or using an automated irrigation or aspiration cannula. In DSEC, after preparing the host, then we move to preparation of the donor tissue. Donor tissue can be prepared either manually, or an pre-cut tissue can be availed from the eye bank. Various techniques have been described for inserting the donor tissue. The first technique that was described was taco fold. Taco fold is folding the donor lenticule into 60-40 fold, followed by insertion in non-coapting forceps. But in this technique, the tissue loss, the endothelial loss was about 34%. Then the second came was with the Busin glide. The Busin glide is a specialized instrument that can load and carry the lenticule with endothelial side up and helps in inserting the lenticule using pull-through technique. Here, the endothelial loss is around 25%. Then is the sheath glide and the Tan's endoglide. Those also have a very less endothelial cell loss. And the technique that I prefer is using a sheath glide insertion. Then anterior chamber tamponade is achieved by inserting air, like the donor tissue is inserted, and then full chamber air is injected for adequate apposition with the stroma of the host. The air fill is up to 7 to 10%. Then after 7 to 10 minutes, a partial air is removal to avoid like pupillary block post-operatively. Then this is a case where ultra-thin DSEC was done, and this is the post-operative image. Over the time, the patient had a very good visual outcome. The most recent one that is being done is Descemet membrane endothelial keratoplasty. In DSEC, some amount of stroma is there, but in DMEC, there is no stromal tissue which is transferred. Only donor DM and endothelial cells are transferred. Thus, the recipient cornea retains its optical quality with no interface, and majority of these patients attain 20/20 vision. And the physiological properties of DM to roll on itself makes procedure more demanding, and the surgical steps are like more challenging, and the learning curve is very steep. DMEC indications are similar to DSEC, but DMEC is by the early surgeons, they prefer doing very simpler cases like Fuchs dystrophy or pseudophakic bullous keratopathy, which is not complicated, or where there is no vitreous loss, or like clear cases are preferred in DMEC. DMEC donor preparation is done either by like a direct peel method is done in a BSS placed solution, like the tissue is placed in a Teflon block which is filled with BSS, and the donor is stripped from the at the trabecular meshwork at the periphery. First, a 10 mm trephine is used for separating the donor tissue from the periphery, and then after detachment, the DM curls up with the endothelium on outside. Then the DM is stained at each step with the trypan glue to have a good visualization how it is being peeled off. Then after the DM is prepared, while preparing, the marking has to be done like either a S mark or P mark, or like an F mark, which helps in aiding the position of the graft in the anterior chamber. The recipient eye is prepared by marking the epithelium with a trephine, then to indicate the planned graft diameter. Scoring of the DM is just inside the mark, and removing the DM from within the scored area. Then usually the scoring as compared to DSEC, the DMEC scoring is bigger, more than 9 mm scoring has to be done. And then the DM is peeled off and removed. For inserting the donor Descemet membrane, various techniques have been described. The cannula, a special glass cannula is used for inserting the donor tissue, that is called as the Goyder's cannula. And the Goyder's cannula is used to inject the donor tissue inside the eye, and while inserting, after inserting, there are various techniques to help us assess that how is the graft oriented inside the eye. One famous technique is Matsuri's sign. Matsuri's sign is the preferable orientation should be that the endothelium should be facing curled inside. So curled inside, and when you insert the tip of a cannula in the AC, the cannula should turn blue. So which tells us that the graft is oriented properly. Graft positioning in DMEC is done like by various cannula methods are there, by like double bumping from each side. There are various techniques, and small bubble is used for orienting the graft and opening the graft in the AC properly. There are various techniques. Then this was the one of the case where DMEC was done, and the patient had a very good outcome after like a week itself. And the people are preferring DMEC now because it is more of an anatomically more natural and lesser risk of rejection and lesser use of steroids, better visual quality and predictable IOL power, faster recovery and refractive predictability. To conclude, there are multiple types of keratoplasty available from penetrating to lamellar. The choice of procedure mainly depends upon the pathology and depth of the corneal involvement and upon surgeon's expertise. And trend is shifting towards lamellar keratoplasties due to the faster recovery and lower rejection rates. Penetrating keratoplasty remains valuable in full thickness pathology and in complex cases. But the future is like personalized surgery, where endothelial cell therapy and artificial corneas bioengineered corneas have come up. Thank you.
Yeah, thank you, Dr. Neha. Excellent talk. So tell me if you have a patient with Ahmed valve and with decompensated cornea, what would you prefer, DMAC or DSEC?
Ma'am, DSEC can be done. Again, like for me, like I have been doing such cases, but for me, I'll be preferring DSEC for these cases.
Yes. But what is the reason for the benefit of our postgraduate? Why not DMAC?
DSEC, ma'am, again, the graft attachment is like very easy. And the blockage, usually the tube gets blocked. The Ahmed valve also gets blocked by using many of the manuring that we do.
Yes. So that is the main reason the Ahmed valve will be blocked. And for DMAC, you need a long-standing, you have to nearly fill the anterior chamber with air bubble for, complete fill should be there. And then the Ahmed valve. The Ahmed valve
reaction also comes, a lot of fibrin reaction happens during DMEC surgery. So that also can block the Ahmed valve.
Usually it will not. If your surgery has been uneventful and there is no new vascularization, that would not be there usually. But the main reason is for the blockage of the Ahmed valve, the DSECT or the ultra thin DSECT that you showed would be ideal.
Okay.
Thank you so much, Dr. We go on now next, moving on to Dr. Pooja. I know your topic is very elaborate, plus try to finish in time. I think it is nearly...
Nobody is finishing on time. Seema's talk was 18 minutes. Everybody is taking so much of time. So, PGs are, I must be sleeping. मैं क्या करूं? Nobody is listening. See, be short and sweet.
Okay, ma'am. Are my slides visible?
Yeah. You start sharing, yes.
I hope the PGs are not sleepy yet. So
can you go on the slide mode, please? Yeah.
Yeah. It's in the slide mode, ma'am?
No, we can... it is. We can see your slides, but just press the... You have to go for the full screen.
Yeah, I have put it in the full screen only.
Now it will come. Okay, no? Anyway, please start. It's still the same. Anyway, please start, Dr. Pooja.
Yes, ma'am. So my talk is on slit lamp biomicroscopy, which will cover the slit lamp examination techniques. So why it's called as slit lamp biomicroscopy? Because we are doing the dynamic examination of a living eye and ocular adnexa. It's a misnomer since slit is only one of the various diaphragmatic opening present in the instrument, and it's an important tool for ophthalmologists to visualize the eye in 3 dimensions. And why do we need a slit lamp? Because as we know, eye is a small structure and it's very difficult to see the details by simple torchlight examination. And we have to make out the relative position of the lesion. So for that, we need a slit lamp. And we also need to see the lesion in oblique illumination. Need for magnification and need for binocularity is there. Little bit history. It was first... microscopy was first applied by Purkinje to the living eye. He studied the iris with adjustable microscope, which was followed by Louis de Wecker. He gave a concept of uniocular slit lamp. he combined the eyepiece, objective, and condensing lens within a tube, and which was upgraded by Zapsky. He added binocularity to the microscope. So this name you have to remember, Alvar Gullstrand. He got a Nobel Prize in Physiology and Medicine in 1911. Henkel and Vogt, he improved upon Gullstrand's device in 1911, which was combined by Zapsky's microscope and Gullstrand's slit lamp illumination. So briefly, I would tell the parts of a slit lamp. So first is illumination system, observation system, and mechanical system. So illumination system, light source is a low voltage incandescent lamp or a halogen lamp. So based on the illumination system, we can divide into two parts, which is a Hackstraight type, Zeiss type. So in the Hackstraight type, you can see the topmost part is the illumination part, but in the Zeiss type, the illumination system is somewhat lower than the observation system. So here you can see this is the illumination system, this is the headrest, this is the chin rest, and this is the joystick, the eyepiece. I'll discuss one by one. Below the platform, there is a power unit. In the observation system, it covers a magnification. So there's a 5-step magnification, and you also get a 3-step magnification. In observation system also includes the eyepiece. Eyepiece, you can see here, this is the neutral position, which is set at 0, and on your left side, it's mostly minus, and right side is the plus. You can also attach a long tube through which you can visualize simultaneously. So here, this is very useful for teaching PG students.
Pooja,
Mechanical support. Yes, ma'am.
can you put it on slideshow?
It's in slideshow only, ma'am.
Slideshow mein hai?
Let me share again.
No, she tried putting, it is not going.
Acha, okay.
I'll share once again.
PGs, are you there?
Yes, ma'am.
I know it's a little long, but this is a very important topic. Don't sleep off.
Both the last ones are very important. The next one, chemical injuries, is also very important.
Yes.
So please bear with us. We can all meet over in JHOS conference for tea together and have a group photograph. Okay, this is very important. Please listen this very carefully. Slit lamp
PG,
exam.
this topic is very, very important. So don't sleep. Okay. I have made few videos also, so I'll try to make it easy for you to understand. So I was talking about this mechanical support. Ma'am, just let me know if I'm in slideshow mode.
No, you are not. You have to go and press that slide wala niche, the right one.
Actually, in my laptop, it's showing slides only. I don't know why it's not showing there.
Then go full screen.
Yeah, it's in full screen mode only, ma'am.
Again press. Down.
Actually, it's showing full screen only to me. So,
okay, no problem. You continue because it will be very late now. Yeah, please finish it.
Yeah, yes, ma'am. So this is the mechanical support. Here you can see this is a joystick which is over the low friction plate, and here you can see front, back, and sideways. Okay, so this comes with a joystick with a fixation target, and mechanical coupling can also be done. Now looking at the position of the patient, here you can see in this area there is a black mark which is the canthal alignment mark. So this is very important because once the patient puts his head on this area, the little canthus is supposed to align with this canthal alignment mark. So your examination will be very easy. There are some special situations in pediatric and elderly patients where you have to adjust the height of the patient. So based on that, you have to make arrangements, like you can make the child sit over a stool, and or if the patient is wheelchair bound, then you can examine the patient accordingly. Now in the illumination arm, here you can see there is a knob there. So with this knob you can basically adjust the width of the slit. Okay, and over here in the just below the condensing lens, you can see a diaphragm over here which gives you the scale reading. So with this knob, you can basically adjust the reading. So why this scale is important? Because there are a few lesions which require the measurement, such in case of corneal ulcers or epithelial defect, or if you want to measure any lesion. So this diaphragm is really important. Similarly, in the illumination arm, this arm you can tilt also, and you can tilt and examine the vitreous. Sometimes vitreous cells and vitritis can be missed, but by
I think your video is stuck. We cannot see the measuring and all that. It is stuck on the joystick only.
Oh. Now can you see this slide, ma'am, on filters?
No. We are only seeing that photo of the joystick, slide number 14.
Okay.
Now, yes. Filters has come now. Yes.
Okay.
Yes. So maybe your slides are not moving. Yeah. Now you start the.
Okay.
Yeah.
Okay. So here you can see the illumination arm. You can tilt the illumination and we can visualize the vitreous to look for any vitreous cells for the diagnosis of vitritis. Now there are various filters: white light filter, gray filter, red green filter, diffuse filter, and cobalt blue filters. So this is present over here. You can see the various markings are there. So this the green filter is basically a cobalt blue filter. The dashed line is a neutral density filter, which is used to examine
the next slide, Dr. Pooja. We are only seeing the screen, which is written filters. Yeah. Yes.
Okay. Why the slides are not showing, ma'am?
Yeah, now it is showing your filters. Yes. Now we can see slide number 21. Yes. Maybe it is not moving.
Yeah.
Okay, go ahead. We can see the filters now, the green one.
Okay. So we can also do the slit lamp photography and videography if the slit lamp is attached to a desktop. So this is very, very useful for documentation purpose. Now coming to illumination techniques, basic illumination, we can divide it into diffuse illumination and focal illumination. So focal illumination techniques is further divided into direct and indirect. Indirect, we have parallel pipette, optical section, conical beam, tangential, specular reflection. And indirect techniques, we have proximal, retroillumination, trans illumination, and sclerotic scatter. So in diffuse illumination, the intensity of light is to maximum. Angle is around 30 degree between the illumination and the observer arm. Beam width is kept to maximum and magnification is minimum. We use filter which is called as diffuser because it gives a diffuse illumination for studying the gross overview of the eye, including lid, conjunctival lesions, and overview of the cornea. So this is the diffuser. You can see in this video, you have to just lift it up so it will diffuse the illumination. Under direct illumination, you can visualize lesions such as here you can see the first lesion is an OSSN and second one is a corneal ulcer. You can also visualize the blebs on diffuse illumination. This is a well elevated bleb along with the cystic blebs. Coming to parallel pipette illumination, intensity is kept maximum and the angle between the illumination and observer arm is around 30 to 45 degrees and the slit width is 2 to 4 mm and magnification is kept moderate. So this type of technique is used to study the size and depth of the lesion. So here you can see the first lesion is the diffuse illumination, but once we make the parallel pipette illumination, you can actually see the depth of the lesion. Here, there is endothelial plaque and the posterior stroma is also edematous along with the descemet stromal folds is nicely seen. In this illumination, you can also visualize prominent corneal nerves. Now coming to optical section is basically same as parallel pipette, but the difference is that here the beam width will be very thin. It will be around 1 to 2 mm. So this will give a detailed examination of cornea, depth and size of the lesion, such as corneal edema, thinning, ectasia. Anterior chamber depth estimation can be done, and you can also grade the cataract. So here in this image, you can see, you can visualize all the 5 layers of the cornea. And this image will tell you about the Van Herrick's grading, which will be seen in optical section. from grade 0 to grade 4. In the next image, you can see the endothelial viral keratitis can be nicely visualized. And on the optical section, you can see the corneal thinning also. You can appreciate it very nicely. In the next image, you can see the stromal melt and hyphema can also be seen very nicely. In this image, descemet membrane detachment can be appreciated. Along with that, the grading of the cataract can also be done by using this method. Coming to conical beam, in this type of illumination, the intensity is kept at maximum and angle between the observer and illumination arm is kept at 45 degrees. Beam width is minimum and magnification is kept maximum. This method is used to detect AC cells and flare. Here in this image, you see the beam width is minimum and magnification is kept higher. So in the anterior chamber, anterior chamber cells and flare can be utilized. In the tangential illumination, the intensity is kept maximum, but the angle is more than 45 degrees. And the beam width is same as parallel pupil, magnification is moderate. So here, if you want to examine the texture of the surface, then this method is very, very important, such as pupillary rough can be examined very nicely, and pseudo exfoliation can also be studied very nicely by using this technique. Now coming to specular reflection, this is very, very important. It can be asked as a single question in your exams. So specular reflection, basically specular comes from a Latin word specularis, which means mirror-like. Specular reflection, reflected image of the light source itself. It follows the principle of Snell's law of optics. It is the angle of reflection equals the angle of incidence, and the brightness of reflection depends on the reflectivity of the surface on which it is seen. So in this specular reflection, what you have to do, you have to make a 60-degree angle between the observer and illumination arm. That is, with the perpendicular axis, 30 degrees each on both sides has to be made. Beam will be parallelepiped with that is 2 to 4 mm, and magnification will be kept high and intensity will be maximum. This method is used to visualize the corneal endothelial cell layer. Here you can see the mosaic pattern of the normal endothelial cell layers. And abnormal corneal endothelium also is used to detect this method. You can identify pigments, heterogeneous cells, guttae, and betel metal appearance can also be detected. Coming to focal indirect proximal illumination, in this intensity is maximum, angle is between 30 to 45 degrees, and beam width is parallelepiped. So here you are not directly visualizing over the cornea. In the adjacent area, you are focusing the illumination. So any obesities, foreign body, or conjunctival cyst can be examined. So here you can see certain nevi can be examined very nicely. Coming to retro illumination techniques, consist of iris illumination and fundus illumination. Iris retro illumination, in this, the intensity is maximum, angle is slightly decentered, beam width is parallelepiped, and magnification is kept moderate. So here you can see the light is incident over the iris and it is reflecting back over the cornea. So here you can visualize fine corneal structures like vacuoles, vessels, and epithelial edema can be visualized. And you can see final vessels over the cornea. There's few pigments also. The Krukenberg spindles over the corneal surface can be visualized by using iris retroillumination. Fundus retroillumination needs to be dilated. Intensity is kept maximum. In this also, angle is slightly decentered. Beam width is short. So posterior subcapsular and any lens capsule ecology can be visualized. So here you can see posterior capsular opacification is seen very nicely in fundus retroillumination. Iris trans illumination. In this, you have to remember the angle should be kept coaxial, and the beam width is a circular beam, and this will whatever light is reflecting over the cornea, it reflects back over the iris, and any iris defects or pigment dispersion or PI patency can be checked by using this iris transillumination technique. So these are few images of iris defects. Coming to sclerotic scatter, this is also a very important technique which you have to remember. Here, this is the principle of sclerotic scatter. First, we have to focus the light at the limbus, and there is a principle of internal reflection along the outermost and innermost surfaces of the cornea. Any obstruction in the path of the light, which what it will do, it will scatter light. So it helps in differentiation of a scar from infiltrate. So there is visualization of corneal dystrophies by using this principle of sclerotic scatter. So here you can see the light is illuminated from the distal end, from the at the limbus, and due to sclerotic scatter, the scarred area is it's highlighted very nicely. In this image, you can see due to sclerotic scatter, the intacts have been highlighted very nicely. And in the next image, the infiltrates are also seen very properly by using this technique. Now coming to special filters, we have already, it was shown by previous speakers that we use fluorescent rose bengal and lissamine green staining. So this stain is very useful for identification of the for demarcating the lesion and to highlight the epithelial dip, and also it can be used to detect the serial test, which was shown by the previous speaker. This image shows the staining of the rose bengal staining, and here you can see lissamine green staining, which is used in dry eye estimation. Now, additional uses of slit lamp, you can also do Goldman applanation tonometry by using the fluorescent dye, and contact lens fitting is also done. Fundus evaluation by using your 90D and 78D slit lamp photography and videos can be done. Anterior chamber angle assessment along with gonioscopy can also be done. And slit lamp is also useful for doing your corneal scraping and suture removals, AC reformation and bleb needling, toric marking can also be done. Next important thing is examination of the donor cornea. So in eye banking, usually we get donor cornea, but we need to examine the cornea, whether the cornea is of therapeutic grade and optical grade. So we can mount a holder-like thing in the slit lamp, and there in the below there is a mirror. So whatever cornea is being placed here, the mirror image is shown over here, and you can examine the cornea through slit lamp. So this is how it looks. If the cornea is very clear, there are few decimal folds and there is no epithelial defect, you can label it as optical grade. But if you deem an epithelial defect more than 50% is there, this will be graded as a therapeutic grade. So there is a grading system for this. I have not gone into so much of details of it. You need to know that slit lamp can also be used for grading of these donor corneas. Suture removal and gonioscopy also I have mentioned. This is very important. Toric marking under slit lamp. So here you have to position the slit beams around 1 mm of slit beam horizontally, and at 0 and 180 degree you have to mark with marker pen. So this is very, very important. So conclusion, slit lamp examination is an indispensable part of a complete ocular examination, interplay between illumination and observation, a skill that must be perfected. The more we use it, the better we become. So thorough knowledge and repeated practice of all the examination technique is the key of becoming a good clinician. That's all from my side. Thank you.
Thank you, Dr. Pooja. That was very beautiful. Lot of videos, lot of learning. And Dr. Poonam, are you ready with your slides?
Yes, ma'am, I'm sharing.
So, Dr. Pooja, by the time she's sharing, when you are doing the marking on slit lamp for toric, you
Yes,
do it before dilatation or after dilatation? And do you use needle or a pen, marking pen?
Ma'am, I do it after dilatation only. And first I scratch it with a 26 gauge needle. And then I put a marker pen so that the marking does not go away when the patient blinks or when the patient is getting a block or something. So first I use a needle and then I overlap it with a marker pen.
We mark by crescent, me and my husband, Dr. Kashyap, and then we stain by trypan blue.
So, ma'am, you also do after dilatation or before dilatation?
Actually, we don't mark. Actually, we have Varion, that is a digital marker. Yes, but we do above that also after dilatation.
Okay, thank you.
Because we have all the time digital markers showing, axis.
Yes.
Still we mark by crescent and then by triplet blue.
Very nice. Thank you, ma'am. Dr. Poonam, last talk.
Yes, ma'am.
The least very important.
My slides are visible, ma'am?
Yes, absolutely visible. Please start.
So good evening all. I'll be talking on management of acute chemical injury. So it's a true ocular emergency and every ophthalmologist should know how to deal with it. Mostly children and young males are at risk. So coming to the sources of chemical injury, alkaline injuries are more common as they are available in various household items like in drain cleaners and cleaning agents. Among all the alkaline substances, lime is the most common and is the most devastating. Coming to acid, sulfuric acid is found in car battery blasts and it is also in the water which is used in inverter. So we also see very often inverter battery blasts. These are near neutral substances which has neutral pH. So these causes more of discomfort than any ocular damage. So mostly max it causes epithelial defect. Coming to pathophysiology, acid injury, basically what happens is acid causes denaturation of epithelial protein. So it forms a coagulum which acts as a barrier. So it prevents further penetration of acid. So surprisingly, acid is less damaging as compared to alkali. And it also causes collagen shrinkage. So it leads to rise in intraocular pressure. Only exception is hydrofluoric acid, which has penetration same as alkali. And on the other hand, alkaline injury, it causes saponification of the lipids in the cell membrane and stromal lipids. And further, it causes cell lysis. And these lytic cells releases proteolytic enzymes and which perpetuate further damage. And it also causes deeper penetration of the alkaline agent. Now, whether acid or alkali, both causes necrosis of conjunctival and corneal epithelium, and also disruption and occlusion of limbal vasculature. Both the mechanism causes loss of limbal stem cells, thus leading to persistent epithelial defect and sterile corneal ulceration. And in future, the cascade, the sequelae follows of conjunctivalization and vascularization of the corneal surface. Coming to management part, I'll be covering the immediate and the early acute phase treatment. Now, the first thing first, we have to check the pH if litmus paper is available, and we have to quickly initiate the irrigation part using 1 to 3 liters of the solution for 30 minutes. And in between, like after 10 minutes, we should check the pH and we need to irrigate till we achieve the physiological range, that is 7 to 7.2. We must also double evert using Demar retractor and to see whether there are any particulate matter that has to be removed. And after that, we should go for slit lamp examination with fluorescent staining, and also we should grade the severity of the injury. Now, this is one of the case where the patient has reached after consulting elsewhere, and on double eversion, we could see there was a plaque of tuna in the upper fornix, which was causing constant bleaching of the agent and causing further damage. Now, to irrigate, we have in hospital setup, we have balanced salt solution, which is preferred. And we have wrinkle lactate and sodium chloride. Though at the site of the injury, whatever is available, as simple as tap water, should be used as the time when we initiate the irrigation or the primary treatment also influences the visual prognosis in future. So ideal solution is diphoterin solution, as it is hypertonic and amphoteric solution which can be used in alkali and acid injury. It dissolves corrosive out of the corneal tissue, and it quickly neutralizes the pH to physiological range and also leads to faster reepithelialization of the stroma. Now, coming to classification of chemical injury, it's basically to to tell us the severity of the injury and to help us approach to the treatment and most importantly to prognosticate. Now, severity of ocular injury, as mentioned, also depends on toxicity of chemicals and how long the chemical was in contact with the eye, and initiation of the primary treatment and depth of penetration of the chemical. So history is most important. Now, this is for postgraduate. Basically, how does the limbal ischemia looks? You see this area of white glossy appearance where there are obliteration of vessels Also in conjunctiva, you can see that these areas are devoid of vessels. So this tells us that the area is ischemic. Now this Roper-Hall classification was given in 1965, where limbal ischemia and corneal involvement was taken into account. Conjunctival involvement was not included, and the chemical injury was graded into 4 grades. But later on in the studies, it was seen that not all grade 4 categorized as per Roper-Hall had poor prognosis. So came Dua's classification, in which this 4th grade was further classified into 3 grades, and it took into account limbal involvement as well as conjunctival involvement. So it was seen that Dua's classification was way better in predicting the outcome in severe burns as compared to Roper-Hall classification. Now coming to medical management, we must know the phase of recovery. And in first week, the epithelium regrows. In second to third week, collagenase activity is at peak. And in later phase, the mild to moderate cases, they heal, and severe cases may undergo melt, scar, or total LSCD. So early phase treatment of early phase, that is grade 1 and grade 2, aims basically at promoting epithelialization, preventing corneal melt, preventing cicatrization, controlling IOP, and to reduce inflammation. So steroids are the basic mainstay of the treatment, as it decreases the inflammatory cell infiltrate and stabilizes the cell membranes. Prednisolone can be started in mild to moderate cases 4 times, and severe cases it can go hourly. But we must remember that after 1 week, we must taper off steroids, as it inhibits epithelialization and collagen synthesis. Do not hesitate even if there is epithelial defect present. Antibiotics are given to prevent superinfection, and 4th generation fluoroquinolones, moxifloxacin is preferable, and lubricants to provide comfort. Basically, preservative-free are used so that it is less surface toxic. Now, vitamin C, what happens is when chemical reaches ciliary epithelium, it causes vascular damage, and there is decrease in aqueous humor ascorbate level, and it further decreases the collagen synthesis. So we have to give supplements orally. So 500 mg tablet is given QID. Cycloplegics are basically for comfort. Atropine or homide can be given. Now doxycycline 100 mg BD in grade 2 and above we have to give, not in grade 1. So this apart from the doxycycline, apart from its antimicrobial effect, it inhibits matrix metalloproteinases and thus decreases the collagen breakdown and helps in reducing the ocular inflammation. Must be avoided in children and pregnant females. Now the biologic substances have also been tried. 20% autologous serum, especially for persistent epithelial defect. Umbilical cord blood serum, platelet-rich plasma, amniotic membrane suspension. So these things basically have growth factors which promote epithelialization. These are protein-rich, so we must be vigilant for any kind of contamination. So in this study by Sharma et al., it was seen that umbilical cord blood serum was found to be way better than autologous serum in terms of epithelialization. Coming to surgical management, it consists of, we have options of debridement, amniotic membrane transplant, conjunctival advancement, tenonplasty, and alloslet. So amniotic membrane transplant basically promotes, amniotic membrane graft basically promotes proliferation of conjunctival and limbal epithelial stem cells. It aids in healing and also gives symptomatic relief. This is one of the cases where amniotic membrane transplant was done in the 2nd week, and we can see that the inflammation was reduced significantly. In this patient who are not systemically well, we have Procera, and also by Orolab, Oro Amcerter, which can be used. So role of amniotic membrane transplant in acute chemical injury, all these studies have shown that it has better rate of epithelialization, as well as there was significant reduction in the discomfort to the patient. Now coming to tenonplasty, it is especially helpful in episcleral and scleral ischemia, where we do advancement of conjunctiva and tenons to the ischemic area. So basically we re-establish the limbal vascularity and helps prevent melt. Now, this is a new thing which has Geeta Iyer et al. Have shown that aloe slit, which was done in 18 eyes with grade 4 and above chemical injury, who presented with non-healing epithelial defect 1 month post-injury, even after medical and surgical intervention. They had shown that they, after aloe slit, they achieved rapid epithelialization, and also later on, the need of keratoplasty, lamellar or penetrating, was reduced. So the management goal in acute chemical injury is, they say that the best result that can be obtained in severe chemical injury is totally vascularized and scarred cornea that has not undergone ulceration and has not developed glaucoma. Prevention is better than cure. Proper labeling on chemicals, work with proper safety protection, placing it away from children's reach, and awareness program for hazardous workplace workers. Thank you.
Thank you, Dr. Poonam. Excellent talk. And I think you have covered most of the things. And have you ever done tenonplasty here? I have not yet seen grade
No,
4.
ma'am. I went.
Yeah. So
can I make a point?
Yes, yes, please, doctor.
Sure, sir.
Prafulla Marana is here.
आपका webinar है, how can I leave? So chemical injury, you know, you Dr. Poonam, you did you took a great lecture. There are few points that I'll just update the residents here. And one is, Dr. Poonam, what is the choice of fluid for irrigation? You should know in the emergency stages, because that's a very common question. Suppose you are in a setup where you don't have normal saline ringer lactate. So what would advise to the students with what they can do a saline wash?
So ringer lactate is preferable, sir. Balance, it also comes
so
under
ringer
balance or
lactate is
solution.
preferred. Yes,
Because
and
the composition is same as plasma composition.
Yes. So if nothing is available, remember any sterile
water.
fluid, right? Even you can use normal saline or simple bottle distilled water also. But if nothing is available, that is the very important thing you people should remember. And second, there is an excellent article in BGO in 1984. So all of those who are interested in chemical engineering should go back and read that. That is by Harminder Dua sir. So all the inflammation, everything is because of the epithelium. The moment your epithelium is off, it induces a chain of reaction. That inflammation that damages the surface. So for all practical purposes, the ultimate goal is management of acute chemical injuries to cover the epithelium. So nowadays, if you have access to AMG, it's always good to put the AMG. If you see there is epithelial defect, you have started steroid and all these drugs, and there is no signs of epithelial healing, there is you have to go for a AMG. And one advantage of doing AMG is that forms a layer. Suppose a pannus forms over the cornea, and 6 months later you are planning a slit or a DALC. So AMG will give you a plane of separation and a smooth bed. That is the biggest advantage of doing AMG. About alloslet, yes, Dr. Geeta Iyer, she has given excellent result with that. But it will for all of us, for general practitioner or fellows, resident. So even if you are not doing slit, do a AMG if the epithelial defect is not healing. The moment you cover the epithelium, inflammation, everything goes down. Thank you.
Yeah,
Thank you for your discussion and joining after coming back.
For all corneal surgeons, chemical injury very special topic.
Yes.
They want to discuss that because immediate management makes a huge difference in patients' long-term outcome. And it changes life of people. We don't realize that point of time, but it completely changes the life of people. If you have time, 2 days back only, we have cleared a girl who has cleared UPSC, and because of chemical injury sequelae, she was disabled, and now she has cleared UPSC. But in Supreme Court of India, when we cleared that, yes, she can go ahead, then it was appreciated by everyone. But the only negative point was she became disabled because the immediate management was not properly done. So it can make a huge difference in people's life.
Yes.
So take acute chemical injury management seriously. and do whatever you can do, but give them a good surface. Thank you,
Thank
ma'am.
you all. Thank you very much. And I am seeing that all the PG students, everyone is still connected. And I don't know, from Jamshedpur, all the PG students are connected. Dr. Bharti, Seema,
Yes, ma'am, they are there.
they are there. So
They are there, ma'am.
okay.
Had a talk to
Please
them.
vote for Dr. Prafulla.
Yeah.
He's from RP Center, Cornea Department. He can help also our PG students.
Thank you, ma'am. And
Prafulla.
PG
Thank
student,
you.
please read my book, Ophthalmology Clinics.
You have written a lot of books. लाइब्रेरी में एक दो बुक भेज दो ना.
आपके
मध्य प्रदेश के ये सॉरी MGM के लाइब्रेरी में भेज दो, हमारे लाइब्रेरी में भेज दो, TMHA के लाइब्रेरी में भेज दो.
बिल्कुल मैम.
बहुत अच्छा होगा.
Dr. Praful, I just wanted to ask one thing.
Yes, ma'am.
Regarding the chemical injury. Actually,
Yes.
many a times we are not in a position to procure the AMG also. So in that conditions, if I try to use the conjunctival tissue from the other eye, then will that help later on removal and after the panis formation? Can we, I mean, somehow, I've been like, I'm from a government institute. I just keep on experimenting so that the cost factor and all those things can be like cut off for the patient, because the patient is not at all ready to pay. So that is one biggest limitation over here. So can there be
Injectable allograft, even there is a recent paper on that. If you don't have anything, then you can try that. But the only problem with conjunctival graft is it may induce vascularization, which may jeopardize your future graft. So as far as possible, don't use it. But if you have nothing and the epithelial not healing, you have to cover it. If you don't cover, then the entire cornea will melt. So you have to use that. And one thing, there are dry AMGs also available, and this can be ordered online also, because few years back I was in an institute which doesn't have any access to AMG, cryopreserved AMG.
Yeah,
So it
the
comes
thing
as
is, I told you one limitation, not because the patient is not ready to pay. That is one thing. I mean, how
so
to
in that
procure,
case,
what to do in that case
you have to
whenever
do
when
that.
you are not having anything. So that
Yeah.
that was actually my question. So I just want to know if there
Yeah,
is
you
any
have to cover the epithelium with whatever
Yeah.
possible mean.
So I mean, that can be tried, isn't it?
Yes.
Seema ma'am, hi, good evening. I was just trying to say that we are procuring AMG also, and we are preparing it from the placenta as well. So almost
Like,
all the
ma'am,
patients
actually,
who do require.
We used to prepare it in our in a UG, I mean, in a PG time. So we used to do it, take the fresh ones, and we used to use it. But the fresh ones are not, I mean, advisable these days because of the, I mean, ethical issues and the medical legal points. So
He's
you're
not taking
procuring,
fresh
what is
one.
the cost of like, I mean, if you're
Fresh
procuring, what is the
निकाल के लाते थे. We used to do.
हाँ करते थे मैम, पर अभी it's not possible. So what is the cost that you provide, ma'am? I mean,
It depends on the size. It comes for 2,500, 3,000, 3,500 also, depending on the size. But the cost factor which comes into place with AMT is that if you are using glue, because tissel glue now is, I think, upwards of 14,000. So that is one thing. But if you're using
I mean,
sutures,
glue is like no glue. To it's not like I mean, cost.
It's not
be paid by
absolutely
the patient.
compulsory. It's not absolutely compulsory. But when you have very large surfaces and you want the AMT to stick, glue really helps, because you can only do anchoring sutures at the edges. But
Obviously,
glue
it
is required,
helps.
else it slips.
It definitely helps. But I told you now, the biggest limitation over here in our institutes is the cost factor. So I mean, we actually have to make improvisements into the techniques and all those things so that we can actually help the patient without actually increasing the cost. So
yeah, but talking about conjunctival graft, the biggest problem with chemical injury patients are, in fact, even when they are up for slit, they really don't want their other eye to be touched. Many times they do
Yes.
have bilateral injuries, but if someone having an acute injury and you tell them that it's a bad prognosis, and then we are going to, take out something from your other eye, in that case, most of them do not agree. Even after 6 months, they don't want, even a slit to be done if
Yeah,
this is touching the other eye.
that's what I'm telling. The actual problem is that they don't want to pay also. So what is the best that can be done? Just to serve them. What is the best? What are the possible things that I can do? I just keep on exploring all those things. So maybe
Keep on exploring, also keep the data, that will enlighten us also.
I'll keep on trying, sir. So maybe someday or the other, everything will.
Being
We
a
will be
clinical
accessing everything.
scientist, that is our job basically.
Yes,
In
that's the best.
India, whatever the technique that Western people come up, or institute like RP Center, whatever I do at RP Center, that may not be feasible for everyone to exactly replicate that. So innovation has to be there, and if you're
Yeah.
trying, it's good, but always
Yeah.
back up with good data. If you keep the data, then that.
Yes.
Sir, I would want to ask that in such cases, if there is no involvement of the fornix, or if there are not chances much of developing a symblepharon, then maybe a tarsography can be done if only the cornea is involved, and the other conjunctival area is not that raw. Maybe if they are not paying, that is a cheaper option if possible.
But most of the
But ma'am,
cases
is
they
that for
do
acute
develop that
cases or
symblepharon.
sequelae cases? Because acute cases, tarsography not a good idea. But yes, your acute phase has gone. Now inflammation is controlled, but you are getting a PED, and there is no resurface. In those cases, it may tarsography will definitely help.
Because then cost effectively, I think that is one thing that you can do.
Yes, tarsography is a very ignored
Almost
topic,
like-
and if you know how to use it, then it does wonder at times.
Sir, what is your take on just putting a BCL if nothing is available?
So,
That-
is the question to me or Dr. Punyam?
Sir, you only.
So for
Can
me,
we use
BCL, you have to understand why the epithelial defect is there in a case of acute chemical injury. So BCL gives you a mechanical protection from lead movement. So it will definitely prevent further trauma to the epithelium. But the defect that is there, which is releasing inflammatory mediators, that is not going to stop. So
that is
for
not-
a post-traumatic epithelial defect, BCL is good enough. Why? Because the underlying cause is different. It's a mechanical trauma that led to that. Or in the GPC case, it's a mechanical trauma. But for chemical injury, the underlying mechanism is different. BCL is not going to help you that much unless you take care of the basic mechanism why the defect has occurred and why and the inflammation that is going on unless you take care of that.
Okay, sir.
Bharti ma'am, I told you, chemical injury, very interesting topic. Usually at 11 p.m. also we are discussing till 11:30.
Because it's frequently getting cases now of chemical injury, very common.
That's a very important topic.
Yeah, and
I
most of
think
the patients are like
ma'am is there.
in our institutes. Yeah.
I think we are done here. Thank you. I was listening to all the speakers, especially local speakers. You people are doing great job in spite of all the limitations, financial, patient, but still you people are doing great job. That is what is in fact needed in India.
Thank you, sir.
Somebody call Bharti ma'am. Ma'am has to conclude, I guess.
Yeah, Dr. Nidhi will do that.
I think she must be in the washroom or busy. She's not picking up the call. So I think Seema ma'am, you can conclude it. You can conclude the session.
We actually
she's
had a very nice session because
Hello?
it was It actually, ma'am is coming. Should I conclude or ma'am is coming?
She's here. She's here.
Oh, she's here. Okay.
Yeah. Thank you. Thank you all.
Ma'am,
And
we
for a
were
nice
missing you.
contribution. Scientific contribution. Thank you.
Thank you so much, ma'am. Actually, for bringing us and picking us from all over Jharkhand, from all areas and corners of Jharkhand and bringing us together. That is very important, ma'am.
Oh, JSR lives in my heart and in my mind.
We need your support, of course, every time, ma'am.
But
Just
Pooja,
bringing a
you have
bouquet
not
out of
mentioned that
heart,
you worked in
that's...
Kashyap Memorial Eye Hospital in your CV.
Ma'am, it's all
Pooja,
because
Pooja
of
को
you
मैं
only.
बोल रही हूँ. She did not
Kashyap Memorial
mention.
Eye Hospital. No, ma'am. It's always it's always close to my heart.
मुझे तो लगता ही नहीं है कि she has gone to Jamshedpur. मुझे तो लगता है कि she is still in Ranchi with us. And she has given voice to so many of my surgical videos. So chalo.
Today my voice is down, ma'am.
I know,
I'm
but
down with
you
URI.
did you follow my instructions? And
is busy doing panoptics.
विभूति उधर से बोल रहा है कि पूजा is busy doing panoptics.
Her name is Dr. Panoptics.
And your name is Dr. Panoptics. विभूति is saying. उसको सब खबर है.
Thank you so much, sir.
ठीक है, चलो मिलते हैं. बाय बाय प्रफुल्ला, बाय सीमा, बाय पूजा, बाय डॉक्टर भारती, and bye all the PGs, and thank you to
Bye,
Indot Rahul Jain.
Good night,
Vibhuti,
everyone.
Okay, bye.
Thank you. Night, sir. Night, ma'am.